I will say that type 1 diabetes ended up being one of the greatest assets I've ever had in my life. It has allowed me to connect with a lot of people and given me tremendous purpose in my life to really take my understanding of being forced to understand everything about how your metabolism works and being your own metabolic manipulator of every day, of every single meal, and the insights that you can gain from that and how it can translate to other people.
Welcome to Metabolic Mind, a nonprofit initiative of Bazooki Group, transforming the study and treatment of mental disorders by exploring the connection between metabolism and brain health. Thank you for joining us on this journey. Andrew Koutnik is a PhD researcher focusing on diabetes research and nutrition and lifestyle, specifically ketogenic interventions. And he's not just a researcher, he's a patient who lives with type 1 diabetes and an advocate in this community. And he's going to talk about ketogenic interventions for type 1 diabetes, what that does for normalizing glucose and reducing complications. He's going to talk about his 10-year case study that he recently published about using ketogenic interventions for 10 years to treat type 1 diabetes. And we're going to weave in the association of type 1 diabetes, blood sugar abnormalities, and mental disorders and psychiatric diagnoses. So stay tuned for a packed interview with Andrew Koutnik. All right, Andrew Koutnik, thanks so much for joining me today at Metabolic Mind.
Hey, Bret, it's an honor to be here.
Yeah, it was an absolute pleasure to spend some time with you at the American Diabetes Association conference recently. And, after talking to you, it was just clear we've got to get you on the podcast, the website, the YouTube page, because you have so much to talk about. We've got your story individually, which is fascinating. We've got the recent paper you just published about a 10-year case study of ketogenic intervention for type 1 diabetes. And then we've got your knowledge and the deep dive you did about the connection between type 1 diabetes and the risk for mental health conditions or mental disorders. So a lot to talk about, but let's start with you. I mean, here you are, you're a researcher in diabetes at the Sansum Diabetes Research Institute, but this all started with a personal journey of you having type 1 diabetes. So how did you go from having type 1 diabetes to finding a ketogenic intervention as a way to help manage it?
Bret, yeah, I have to say, if I didn't have type 1 diabetes, I don't think we'd be speaking here today. I don't think I would be doing the research I'm doing. And this goes back over, I think, 17 years now. So I guess I should start by saying that I grew up as an obese adolescent kid. That was really something that I struggled with a lot and, affects self-esteem. And so I started with that, as my first foray into awareness of overall metabolic health and its consequences. But I was mostly focused on the superficial component of that. But I ended up being successful in losing weight. No special diet or any particular strategy. I just eventually found a path that worked, which was just some consistency. And seemingly completely disconnected was a diagnosis a year later with type 1 diabetes, which, for your audience, if they're not familiar with this disease, is in my pancreas, which normally for everyone else who doesn't have type 1 diabetes or maybe late stage type 2, when you eat food, particularly carbohydrates, it increases blood sugar or levels of sugar within the blood as the body breaks down these foods. And your pancreatic beta cells secrete insulin. And the way I like to describe it is it's a lot like a thermostat for blood sugar regulation. As blood sugar goes higher, your body starts releasing more insulin to bring it down. And that happens really quickly. We're talking seconds to minutes. Endogenous insulin almost instantly takes care of things like carbohydrates. But my body, from the best we understand type 1 diabetes today, had an autoimmune attack that attacked my pancreatic beta cells that produce this insulin. And so I no longer have endogenous, this thermostat anymore that controls blood sugar levels. So the rest of my life from that day forward, and I remember it vividly, I now had to be my own metabolic mastermind. I had to understand everything about what I ate, how to exercise, how my sleep schedule, how food patterns, all these different dynamics and how they played into metabolism of both blood glucose regulation, both how much goes into the blood, but also how much insulin I needed to take. Type 1 diabetes really gives people, whether they like it or not, a masterclass into metabolism and understanding almost every factor that can affect your overall metabolic health with two of the most important biomarkers, glucose and insulin. And so I've had type 1 diabetes for about 17 years, but getting diagnosed with type 1 diabetes was really just a continuation of my passion, but took it to a whole nother level. Having type 1 diabetes makes it impossible to ignore the impact of things like food or lifestyle on your metabolic health. It has such a direct impact. And that was my introduction to type 1.
Yeah, and as you go through this and you talk about the masterclass of metabolic health and metabolism, I got to say, it sounds like though you were in the unique situation to be able to dig into that and learn, because the age group most affected by type 1 diabetes is, adolescents and teenagers, where maybe people aren't quite ready for that lesson. And that's one of the, I guess you could say, tragedies of type 1, is it really hits this age group that is trying to fit in and doesn't want to stand out and doesn't have maybe the full emotional intelligence and just intellectual intelligence to dig into this. So it can be a very risky and tricky situation, but it sounds like you were able to manage that pretty well.
Yeah, I want to make a point here, Bret. You bring up a really important point. I really want to dive into this. People often view a disease and a diagnosis as devastating. It's a disease, it's a disorder. You're different than your peers. But I will say that type 1 diabetes ended up being one of the greatest assets I've ever had in my life. And I think that's important for parents of newly diagnosed children and also adults, which actually we now know that the median age of diagnosis is in the 30s for people with type 1 diabetes. It's no longer in adolescence, although a disproportionate number of adolescents are diagnosed because it's a shorter window of time, of course. But if you actually consider the median age, around 30 is the now known median age across the world for type 1 diabetes diagnosis. So it is critical to understand that, yes, anything could be devastating. Yes, anything could affect and destroy your life negatively if you want it to. But you have an opportunity to change your mindset towards that and use it as an asset. And I will tell you, me being diagnosed with type 1 diabetes, not only, Bret, did we get an awesome time to chat this week through that connection that we have a metabolism and its interaction, but it has allowed me to connect with a lot of people and given me tremendous purpose in my life to really take my understanding of being forced to understand everything about how your metabolism works and being your own metabolic manipulator of every day, of every single meal, and the insights that you can gain from that and how it can translate to other people. So I want to make that salient point. But yeah, I did have a keen interest in trying to regulate my lifestyle and to be better. I was, being obese, when I had lost weight, the next thing I wanted to do was flip that. I wanted to become a bodybuilder, be, super lean and super muscular, the polar opposite of what it was. And so I went on that journey, and along the way, I grew to appreciate how important nutrition was for all of these things, not just for trying to be bigger, stronger, faster, and look differently, but also how I felt. And that opens a whole can of worms as I kind of delved into different dietary strategies to manage type 1 diabetes.
Yeah, so let's talk about that. I mean, managing type 1 diabetes, the general recommendations are, you eat your normal meals, eat whatever you want, and just cover it with insulin. So not a problem to eat a ton of carbohydrates. You just calculate how many carbohydrates and calculate the amount of insulin you need to balance that. So it can be this, up and down swings of glucose going up and down. And there's a lot of inaccuracies in doing the exact calculations of what you need to cover. So you were able to find ketogenic interventions, and I want to hear about how that happened, but I want to set the stage that this is just antithetical to anything medicine thinks. And actually, general medicine probably thinks that this is very dangerous to use ketogenic interventions, but the target hemoglobin A1C tends to be around 7, which is not a normal blood sugar, but it's sort of deemed to be the safest, because if you have too much insulin, you try and get too aggressive, you risk hypoglycemia, which can also be very dangerous and very uncomfortable. But tell us about how ketogenic interventions sort of help with this and how you stumbled upon it.
Yeah, a lot to unpack there, Bret, because you touched on a number of topics that I really think are important to address. But to really dive into how I came across, a very low carbohydrate ketogenic diet wasn't on purpose, actually. I wasn't purposeful thinking, oh man, I'm going to do this for X, Y, Z reason. I actually kind of, in the bodybuilding community at that time, there was this hype around ketogenic diets can preserve muscle mass and just eviscerate fat. It just absolutely falls off of you while muscle just stays. And ironically, I ended up studying that for my dissertation, working with Dominique D'Agostino at University of South Florida College of Medicine, But well before that time, I just had been intrigued about this, magic about this diet that people are talking about way back when. This is when Atkins was at peak interest. And what was interesting is I was curious about that. Obviously, this fascinating with being bigger, stronger, faster. And if a dietary intervention could do something about that, I was willing to do anything, like this is my mindset. And so I had the forethought to reach out to someone that I knew from who was a professional athlete that I happened to know, and reached out and said, "Hey, look, I'm kind of interested in going down this path. Do you have any insight?" Because at least at that age, I was young, I at least had the forethought to think someone else has experience. Maybe I should ask them first, and find out from the lived experience. And so I reached out, and they surprisingly called me. This is a professional athlete. They have time for this. But this is what you find often in type 1 or other diseases where it's so impactful to your life. People want to help. People want to be there for you and guide you on your journey. And that conversation ended with, hey, let me help you out. And so they gave me their tools and tricks that they had applied towards, eating low carbohydrate based diets. And this was just a pretty prescriptive. It was focused around protein and fat and having enough fibrous vegetables at each meal. And also, what's often ignored in type 1 diabetes is changing the insulin strategy. In the context of type 1 diabetes, one of the major limitations we have is this disconnect between the endogenous requirements of insulin to metabolize carbohydrates compared to how much slower even the most rapid forms of exogenous insulin are. In fact, the peak between these two is something like 3 to 4-fold different and much slower in exogenous insulin. So it does often require, at least best practice that you hear from patients who are seeing results from this, is to change the insulin strategy to match the glucose impact of food. And food is the biggest impact on glycemia in people with type 1 diabetes. So I was able to learn that pretty quickly from an expert and someone who had lived this and tried to optimize it for their professional athletic path and had been very successful. And so I, tried it, and I thought, man, I'm not really seeing many highs and lows anymore. This is great. I also happened to start performing better, looking better at the gym. This is not to like sprinkle all this magic on top of it. It just so happened to work out that way because I was so prescriptive the other way. I was following a very whole foods based high carbohydrate approach, very much what is recommended under the ADA guidelines. And so I switched, and 3 months later, I walked into my doctor's office, and at the time, he actually happened to be the ADA president, so the American Diabetes Association, and just a wonderful man, one of the best doctors, frankly, maybe the best doctor I've ever had in my life. And he goes, "Andrew, what are you doing?" And I go, "What do you mean?" I'm pretty young at this stage, but I'm thinking, that must be something special. This guy's a legend in the space of diabetes. He said, "Andrew, your HbA1c is 5.6. I never seen that here before. What are you doing?" And I said, "Oh, I must be doing something super special here." He's like, "That's technically not a diabetes HbA1c. You would be considered non-diabetic." And so he actually brought his resident in. He got me to speak at the College of Medicine at that time. He really was super supportive of just, hey, if this is unique and it's working, people should be aware of it, which was really supportive. And so I stumbled upon it like that. And ever since then, I thought, man, ever since I went to that place where I had this really tight glycemic control, and this is before CGMs, okay? This was before the insulin pumps became widely used. I was just seeing this difference subjectively, internally within myself. And also was verifying that by just looking at my blood meter test that was very rarely ever testing outside of 70 to 120. And then, of course, the HbA1c comes back and it's 5.6. And so that was my initial introduction to a ketogenic diet. And ever since then, due to its ability to control glycemia and the ever growing demands of a young man in life, I was at one point working 3 jobs, and I was also on my path to going to graduate school. And then that plus having now 2 young boys, it was no longer about just like, oh, it's about Andrew. Like Andrew can do whatever he wants. There was also a component of how do I make sure that I'm my best self, cognitively, mentally, physically on a regular basis. And so that's why I became so passionate about this interaction between food. It didn't have to be per se that strategy. It was just the clear awareness that something so commonly described as, we know people describe food as medicine, and it clearly is in many respects, but food and exercise or lifestyle habits are just essential things to be healthy. And there's nothing different about that in the context of type 1, but in the context of type 1, it's very unique, Bret, in that we have to manage something very different, in that we don't have endogenous insulin production. We now have to inject exogenous insulin to survive. Okay, if we don't do that, we might not survive more than a few days. And as a result, it requires a different thought on how to manage that disease. What applies to someone who doesn't have this disease frankly, is not the same for someone who has the disease, where you're dealing with these limitations around medication and technology, which has not, frankly, corrected the issue in type 1 diabetes. And we could go down the rabbit hole of the 7% HbA1c if you like, but this is a issue that I'm very passionate about and trying to regulate glycemic control.
Yeah, I mean, gosh, there's just so much more to get into, but just the fact that the doctor, the president of the ADA, who is very familiar with treating type 1 diabetes, was shocked to see a normal A1C. And that just says something about the inadequacy, about the way it's being treated and the role that low carb could have. And it just makes sense. The fewer carbs, the less insulin, the fewer swings, the better blood sugar control. It just makes sense. And you recently did a webinar for the ADA about ketogenic interventions for type 1 diabetes. So I think we might circle back to this, and I certainly recommend anybody who's interested to go to your website and go to Twitter or your X account to learn more about it. But I want to transition, because you did hint at the mental side of things, the mental health, and you did a deep dive to see this connection between mental disorders and psychiatric challenges in those people with type 1 diabetes. So I think this is a really good transition to tell us what you found and how prevalent this association is.
Yeah, this is something that I don't think a lot of people talk about in the context of type 1 diabetes, because why talk about something that you feel you don't have control over? And I want to start with that because I also want to state that I think it is something we can do something about. But in the context of type 1, just like it's expected that people will have prevalent and persistent hyperglycemia, the average HbA1c is somewhere around 8.5 to 8.6, depending on what large scale data you're looking at, which is an estimated HbA1c of over 183 milligrams per deciliter with very large standard deviations. That's expected and normal. In fact, it's expected for all people with type 1 diabetes to have at least one major complication in their lifetime and to live about 11 to 18 years shorter, even in developed countries with all the tools and medications provided. But I don't think
that's the great point. Developed countries, all the tools, all the medications, the latest research, and that's still the best we're doing. I just had to emphasize that point. It's really distressing. But sorry.
Yeah, and Bret, in underdeveloped countries, these numbers climb to a shortened life expectancy by over 40 years. Okay, yeah. So this is what we're dealing with, and this is why I'm so passionate about finding any solution that may help get people closer to better outcomes. And so when you talk about mental health, we know right now, on average, in patients with my disease, type 1 diabetes, that we are expected to see lower IQs on average. These are systematic analyses that have done meta-analyses of literature in kids with type 1 diabetes showing lower and persistent IQ changes. We also have refined data and studies that actually look at MRI analysis of the brain of people with type 1 versus not, in kids too. So this is to emphasize how early this happens. We see neuroanatomical changes in white matter and gray matter. We also know that there's analysis that have shown that been looking at the growth or the developmental trajectory of the brain in kids with type 1 diabetes, and that there appears to be what they call almost a pause or a stalling out of growth and development of certain portions of the brain, at least according to MRI analysis of kids with type 1 diabetes. And the question is, why? Why would someone who's typically normal body weight, although the obesity rates in type 1 have grown, why would someone who's typically normal body weight, doesn't necessarily have dyslipidemia, doesn't necessarily have high adiposity rates, doesn't necessarily have lifestyle based problems in type 1 diabetes, they're seemingly normal, except they don't have a beta cell function that produces insulin and regulates glucose control. Well, a lot of these studies have shown a direct association between higher and higher HbA1c, so higher and higher glucose levels, and these neuroanatomical changes. In fact, we know intervention studies have actually shown in kids that if you just have marginal improvements in HbA1c, not even close to normal, but just taking them from where they are and moving them a half percentage absolute unit in HbA1c, so in the high eights to lower eights, we actually see that that improves neuroanatomical changes in kids with type 1 diabetes. And so we know that high and variable blood glucose levels, which are so pervasive and common, and in fact, frankly, 99% of patients with type 1 do not have normal glycemic control, that we know that high and variable glucose levels cause oxidative stress, they cause inflammation, they also affect a number of other pathways, but these are the ones that are most commonly ascribed to the changes we see in type 1 diabetes. And they not only affect the brain, but they also affect the vasculature. And so this is where it's so important to intervene and improve these risk biomarkers, because beyond that, Bret, we also know that it's not completely reversible, meaning that the impact, kind of like smoking over time, does not appear that you can just stop and improve, and it instantly reverses everything that has already transpired. It's something called metabolic memory. And this was discovered in the DCC and EDIC trial, where they simply took patients from taking 2 injections per day to be more intensive in their insulin management. And what they found is that tighter glycemic control, despite higher insulin levels, despite higher BMI and higher adiposity, and higher incidence of hypoglycemia, actually found much less incidence of microvascular and micro and macrovascular complications in type 1 diabetes. And I think that's important to underscore just how important glycemic control is in type 1 diabetes, and how important it is to do what we can to find strategies to improve it. And again, that draws a connection between what you talk about in the context of mental health, because we know that the diagnosis of mental health disorders post type 1 diabetes diagnosis, okay? So after these people with this disease, the disease I live with every single day, I very much am in tune with why this could be the case. We see almost a doubling of the insulin, sometimes numbers as high as a hazard ratio over 10 for almost every psychiatric disorder post type 1 diabetes diagnosis. And that's incredibly concerning, but it's not a surprise, Bret, because if you actually look at just the acute symptoms of low blood sugar or high blood sugar, which of course is where most people live, is in hyperglycemia, these are physical, but also mental health symptoms. And so just acutely, we know that this can regulate these factors. But of course, long-term, we have data that associates brain changes, cognitive changes, and the higher incidence across the population of type 1 versus not type 1 of psychiatric diagnoses.
Yeah, I mean, so dramatic. Just the symptoms, like you said, of the blood sugar swings, but the neuroanatomical changes. Like I've always known about the microvascular with the eyes and the kidneys, and the macrovascular with the coronary disease, but I never knew about the actual brain anatomy changes, and that just shows how dramatic this poor metabolic health, a result of poor metabolism with high blood sugar, low blood sugar, high insulin, and the dramatic effects that can have, and how that plays out on someone's future with the IQ changes that you mentioned, with the risk of depression, anxiety, other psychiatric disorders. I mean, it's so dramatic, but it's all part of sort of the accepted current treatment of let's not be too aggressive, let's not risk dangerous hypoglycemia, let's keep them in that range. But yet here you have a tool that you have used for yourself, and that there are now published papers, and there are groups surrounding this about using ketogenic interventions for type 1 diabetes that really could just smooth all that out. If it's really all about the blood sugar and we can smooth that out with diet, I mean, to me, it just makes so much sense that this should be standard of care, but it's not. And it seems like there are some big hurdles to get there. So is it that simple that that ketogenic interventions could address all of these issues, but we have roadblocks to get there?
So, Bret, I'm going to answer this as if I was trying to find a solution for my own son. Okay. And trying to dive into what would be all the information I could possibly have about the pros and cons, the risk and benefit side of this, because I would want to know all of that if my son was managing this and I was considering this potential intervention. Right now, we know, because I've conducted a systematic review and also meta-analysis with Belinda Leonards, Tommy Woods, Christy Sorshak, trying to pull every single study ever conducted on carbohydrates, confirmed time on carbohydrates, confirmed type 1 diabetes, and a risk biomarker. But I'm going to focus on HbA1c for a second because we looked at HbA1c. And what we found is that if you look at the grams of carbohydrates consumed, there's a dose-dependent improvement in HbA1c from the average carbohydrate intake in patients with type 1 all the way down to hypothetical zero. Now, while that's observational in nature, it does illustrate that there are a large number of studies at this stage that illustrate tighter and tighter and better glycemic control with lower and lower carbohydrates. At one point, it was very inappropriate to talk about this without acknowledging the vast limitations in the literature. But this data shows across all studies ever done that there's this association between lower carbohydrates and better glycemic control. However, there is no randomized controlled trial, Bret, over 7 days in length on a ketogenic diet in people with type 1 diabetes. And this is despite the ketogenic diet being standard of care for people prior to the discovery of insulin. Keep in mind, the discovery of insulin was early 1920s. And prior to that, low carbohydrate interventions and or fasting actually extended the life of the patient quite a while, because otherwise they would often succumb to hyperglycemia and diabetic ketoacidosis. So it actually helped level things out for a period of time, but it was not inevitable. Like what I mean is it was not, you couldn't do that forever because you had no insulin, and that basically guaranteed the demise of anyone without it. That's why it's essential, even with low carbohydrate interventions, to have insulin in people with type 1. But that said, there have been a number of guidelines around how much people should and shouldn't eat in carbohydrates with type 1 diabetes, despite the lack of evidence actually proving that high carb or low carb is better or superior or worse. But here's the thing. While we do lack this evidence, we also know there's a number of reports, observational, case series reports, uncontrolled interventions, but we do have a 7-day randomized controlled trial. All of these allude to that if you consume less than 50 grams per day of carbohydrates, over 70% of those interventions, 100% of those interventions achieve the ADA guidelines of less than 7% HbA1c. And over 70% of those studies reported a mean HbA1c in the non-diabetic range of less than 5.7%. There's nothing like this, okay? There's no technology, there's no medication that reliably does that, and this illustrates the possibility of that. But because of this lack of, frankly, even reasonable duration and time on this diet in type 1 diabetes, and the hypothetical concerns that have been put out there in the literature from other diseases, such as epilepsy, about doing these very, very rigid forms of a ketogenic diet, not what people are actually doing in the context of type 1, where these are very different things, okay? But they often get confused, and that's something we could dive into. But that was why it was so important for me to see what we could do to address this, both from the systematic review in meta-analysis, but also the unique case of a 10-year report of the long-term safety, clinical efficacy, and cardiovascular physiology of someone who went on a ketogenic diet, achieved normal glycemia, reduced their insulin load, and had elevated LDL for over a 10-year period of time, and looked at the incidence of cardiovascular health. And why that's so important, Bret, is because we know that even in kids with type 1 diabetes, within the first 4 years, we see this trend upward of early signs of atherosclerotic cardiovascular disease progression. And how we actually are able to observe that is something that I studied well over 10 years ago now, back at Florida State, when I first started actually studying cardiovascular physiology. And actually, it was the interaction with brain health that I was looking at. And what we see is that these early signs of cardiovascular disease can actually be seen in things like endothelial function or arterial stiffness, how the vasculature is able to respond to pressure changes or stimulus. And one example is flow-mediated dilation. Essentially, you're kind of putting a cuff around your arm and kind of forcing a lack of blood flow. And then you basically look at the reactive hyperemia, basically this blood flow, how compliant are the blood vessels in response to this stressor of massive blood flow influx. So that's endothelial function, but we can also look at measures of how quickly the blood moves through the body as something called arterial stiffness. And both of these are associated with long-term cardiovascular disease and outcomes, but they're early signs, Bret, of cardiovascular changes. So what we wanted to do is we would not expect someone who's done a ketogenic diet for 10 years per se to have a calcium score, because that's everyone is looking at, is you have calcium score. But the truth is we can see early signs within 4 years, even in kids, of this early adverse vascular changes. And so we did this assessment actually with my friend, Joe Watso, and had confirmed, obviously being on a ketogenic diet for 10 years, no surprise there, normal glycemia, and then actually looked at these measures of cardiovascular physiology. And what we found is that not only were measures of cardiovascular health better than the vast majority of age and sex matched people with type 1 diabetes based on population level norms, but actually as good or better than a lot of people without type 1 diabetes. And that's a case report. So there's a lot of limitations, obviously, around a case report. Like, we can't control all factors. Maybe there's unique protection in this individual, but we don't have any data that goes long-term or beyond 7 days in people with type 1 diabetes. And this was 10 years. Frankly, this matches the longest ever longitudinal report in the literature to date of a ketogenic diet. And to my understanding, the only one that's looked at advanced cardiovascular physiology. It just so happened to be in a patient with advanced progression or high risk for cardiovascular disease, i.e. type 1 diabetes. So there's a lot that can be learned, not only for the field of cardiovascular physiology outside of type 1, but it's a unique story where we're looking at a case where we would see early signs of cardiovascular deterioration within 4 years. And we're looking at this over a decade of a diet that has hypothetical concerns over its cardiovascular health, elevates LDL. LDL has these large Mendelian randomization associations with health outcomes. A lot of trials that have shown improvements in cardiovascular indices, albeit absolute risk is relatively minor. Relative risk is actually pretty high. Things like statins are usually 3 to 6 years, at least, in length. And here we're talking about 10 years. And again, we acknowledge the limitation this present, but it's the longest data we have on this approach. And I think it's an important thing to illustrate how important food is in the context of our overall metabolic health. The implications that it can have are profound in the context of diseases where metabolic health has such an important factor. In fact, I think all of us have to acknowledge that metabolic health is critical to our overall health. The interaction between it and other processes in the body is kind of unlinkable. It affects everything. And you guys are so helpful in educating people on the impact of mental health. And I think type 1 diabetes gives a unique insight into just losing endogenous control of insulin, how impactful just dysglycemia alone can be on overall health, despite usually having better biometrics and other metabolic health markers like lipids and weight and beyond. So I think we can learn a lot from this.
Wow. I mean, I got to take a breath after hearing all that. There's so many good, amazing nuggets in there that are worth exploring. So, I mean, the fact that this individual had better early cardiovascular health markers with the endothelial function than the age match control for type 1 diabetes. Right there is enough. Like, right there is pretty, like, okay, that's impressive. But the fact that it was pretty much the same as someone without type 1 diabetes, like, that's just mind-blowing, that someone with type 1 diabetes could have sort of quote unquote normal vascular function. And like you said, it comes down to the glucose control. And there's, I like to say this like little debate, like, what's more important, LDL or glucose? And in this setting, it's clearly glucose. Now, would that translate to somebody without type 1 diabetes? I think the answer is probably yes, but we can't necessarily say that for sure based on this. But there's other evidence to suggest that with the Women's Health Initiative analysis and other papers recently in New England Journal of Medicine. But just how dramatic it is to say you need to normalize blood sugar, and that's going to take care of the majority of the risk that we see in type 1 diabetes. Sorry for the interruption, but this is a really important point, so I didn't want to gloss over it. But as you can see, this is one of the studies I was talking about, which is a 21-year prospective study from the Women's Health Initiative. And the numbers that you see are what corresponds to the hazard ratio of the baseline condition contributing or being associated with developing heart disease. And you can see down on the bottom, LDL, non-HDL, ApoB, they're not zero, right? They definitely contribute between 1.38 and 1.89. But if you look at a lipoprotein insulin resistance score, which is basically a marker of metabolic health, that's up to 6.4. But look at type 2 diabetes at 10.7. And you can imagine type 1 diabetes would be even higher, which greatly dwarfs the contribution to LDL. So again, not that LDL and ApoB are zero, but when you put it in perspective to the metabolic parameters, it's quite dramatic. And here's a second study from New England Journal of Medicine, also a little complicated. Here, if you're looking at the non-HDL cholesterol increases, right? Again, it's above 1. So you could say that's a marker of LDL. As it increases, so does the risk for cardiovascular disease. But then you go to the right and look at diabetes, type 2 diabetes in this scenario. And again, it's dramatically higher than LDL. So this goes into that context of what we were saying about where do we prioritize, metabolic health or LDL. Okay, sorry for that interruption, but I wanted to emphasize that point. Let's get back to the interview. Now, another question though is, would that then translate to mental health? Again, we don't have the studies to show that, but if it is a direct blood sugar related effect, it seems to make sense that yes, that would also take care of it. Now, this age population being different, having to worry about your blood sugar, all those things aren't necessarily going to go away. But with better blood sugar control, we could definitely assume that there's going to be better mental health outcomes. Wow. All right. There's a number of other things I wanted to bring up. So you made another.
I'll address that real quick and then you jump over.
Yeah.
So we've actually done an analysis, an international survey of people who were patients or caregivers with type 1 diabetes, asking them the impact. Does food have a big impact on your outcomes in type 1 diabetes? Just because a lot of research is so within the lab, meaning like, okay, researchers think that this is what we should study based on where the evidence is right now. And that's, often true. But we do research to help people, right? And what if patients themselves are illustrating that they feel there's something very important and we're not really researching it? And that's certainly the case in the context of very low carbohydrate ketogenic diets. And so what this survey actually showed is that the vast majority of people, over 2/3 of people caring for or living with type 1 diabetes, feel that food has a major impact on their disease management. And actually the vast majority of patients over every other eating strategy, low carbohydrate and or ketogenic diets was the most commonly used today. Now that's a survey. And so take with it what you will, but that's over 1,000 people respondents from North America, Canada, and over 33% international. So we can't ignore that people care about this topic. People want to learn more. And frankly, I think that this is an important topic to discuss, to take the next steps and having better evidence. Because a lot of what you say, Bret, there will always be, what you're saying, Bret, illustrates something I feel is important to acknowledge to the listener. That's the weight of the evidence that we have today. Okay. Yes, there are limitations with the evidence, but we have to take the weight of the evidence that we have today to make decisions, because people are doing this and they're making decisions often with little or no healthcare support. So we need to be actionable in what we say, be careful about how we illustrate the information and knowledge on this, and talk about the limitations, but also acknowledge where the weight of the evidence is right now.
Yeah, and that's a great point. But so with the weight of the evidence now, so let's just do a scenario here. So 20-year-old patient with type 1 diabetes, hemoglobin A1C of 7.8, doesn't have hypoglycemic episodes, has a diagnosis of depression and anxiety, but deemed to be decent control, goes to his doctor or her doctor and says, I heard this guy, Dr. Koutnik, talk, and he's talking about ketogenic interventions for type 1 diabetes. I want to give it a try. What's the response that person is likely to get from their endocrinologist?
Based on our evidence, because we actually surveyed that, unfortunately, a large number of them won't receive very much support. It isn't inherent that they're going to be told don't do it, although that actually has also been reported in about 1/4 of respondents that they are actually advised against this approach. But there isn't any guidelines right now for a physician to feel confident and comfortable with their medical license that they took years and years to earn because they wanted to help patients, but they're also limited by what they can and cannot do around what is ethical. And in the absence of guidelines around how to manage this ketogenic diet strategy in the context of type 1 diabetes, many people will be hesitant or say, If you're going to do it, you're on your own. That's unfortunately very common. And for me, that's why I like to get out and speak about this so much, because I find that that is an unacceptable situation for patients. If you are a patient and you want to have guidance and you want to use a strategy that you think could help you on your health, it's not that physicians don't want to help. It's that they're handicapped by a lack of guidelines that gives evidence-based information about how to implement these, because, Brett, we lack evidence, at least the gold standard randomized controlled trials. But in its absence, we can't wait around to give people who are already doing this information on what the weight of the evidence says. We have to speak about it, because that's what we have today. And then when we have more information, we will update that. But for now, that's where we stand.
Yeah, and I guess to play the devil's advocate and put myself in the position of that endocrinologist, it's not that it's without risk. Like, if you're going to dramatically lower your carbohydrate intake, you need to adjust your insulin commensurate with that. If you don't, you're at very high risk of hypoglycemia. So there's this concern that if someone's not vigilant enough, checking their blood sugar often enough and adjusting their insulin often enough, that they're at risk for hypoglycemia. But as long as you have that discussion and that person is reliable and understands the need for those types of checks, you can really, it seems like you can mitigate that risk. But doctors are, first, do no harm. They're uncomfortable with ketogenic diets. They're really concerned about the dangers of hypoglycemia. And just the term keto in itself, they associate with ketoacidosis. So there are a number of these hurdles. So where would you suggest that someone go to learn more about this on their own? Not that they should do it on their own, but to start learning more, to then maybe bring some more information to their clinician or find another clinician who may be more willing to work with them.
That is a great question, Brett. Yeah, unfortunately, there isn't a ton of resources that someone can say gold standard resource and evidence base. However, of course, people are very familiar with the Bernstein protocol. That's what many people have. If you live under a rock, you may not have heard of it in the context of type 1, but in the context of type 1, there are many patients who pick up that book and kind of go on their own journey. I mean, I'm not advocating for or against that. That's just what people are doing. And there was a actual medical record review, so actual confirmed evidence from their medical records showing the patients who did a Bernstein-esque protocol, many of which who were, because it was from a unique group called the Type 1 Group. And what they found is that the mean HbA1c in that cohort was 5.67. The CGM values were averaging around 100 mean and or median glucose. Standard deviation was, I think, 23 milligrams per deciliter. I mean, these are unheard of, like 1%ers in the context of type 1 diabetes. But a lot of those people follow the Bernstein protocol, and that's a book that people can purchase and read and kind of make their own decisions and talk to their doctor about. I also did not to kind of promote anything per se that I have done. I think Bernstein protocol is a great start, but I did a TED Talk to talk about this actual study and my own personal experience on it, just to bring awareness, because I think that it's something that I don't think I should have been. I didn't know of another person who was doing this for frankly 10 years into. Well, that might be a little exaggeration, but like 7-8 years into having type 1. I didn't know anyone who was doing this approach. I had no idea. I happened to stumble across it because I was familiar with unique communities and a unique person who's a professional athlete doing it. But that's not necessarily what most people are aware of. They don't have those type of same resources, or maybe get lucky enough to stumble across that if they wanted to try this. So right now the resources are incredibly limited, but there are places that people go, and that's often to the Diabetes Solution book, to some of the studies that support that, and also a discussion with a knowledgeable healthcare professional who is willing to support them on their journey. Because at the end of the day, patients are going to do it. And frankly, the evidence says they are. And we need to make sure that we're helping not just the patient, but the healthcare providers who have worked their butts off to earn medical degrees to help patients and guide them on their journey. So it is incredibly important that we're not just focused hypervigilantly on the patient. Of course, we're focused on that because they're the ones who are coming in with a problem. We want to help them. But healthcare providers want to help too. And unfortunately, we're failing them because we don't have guidelines in order to do this. And I know that because I've had many discussions about addressing that gap. In fact, brought it up on the recent webinar that I did, and have worked diligently to try to improve awareness on this topic. But again, how those are done historically is around certain evidence-based criteria. And we just don't have that evidence-based criteria to make deductive choices. So what we know, at least from the American Diabetes Association, is says, well, you can do whatever approach. It needs to be individualized. And so there's that open door for clinicians to go on this journey, except there isn't guidelines to tell them how. So that's a limitation. We do know, though, that the American Pediatric AAPS has a pediatric society has actually recommended against this in kids with type 1 diabetes due to a number of hypothetical risks. And it's supposed to be a systematic review and a meta-analysis. Sorry, not meta-analysis, but systematic review and experts giving guidance on this. But unfortunately, a lot of the original evidence on this was not discussed or talked about. And so there really needs to be a more robust evidence-based discussion on this and its risks and benefits in order to facilitate what type of recommendations and where the evidence stands right now in the context of type 1 diabetes. And I'm really passionate about some of the recent evidence we'll be able to share with the community about where things stand on average across all studies ever done in the context of type 1 diabetes and the impact of carbohydrates has in this disease. And I think it will hopefully open a conversation to advance our awareness of the impact of food in the context of a disease like type 1 diabetes.
All right. Well, we've really covered a lot in this discussion, and it's been fantastic. And I know there's probably more to dig into, but I want to give you the floor one more time to see if there's more you want to bring up here.
Yeah, Bret. Well, first I want to say it's truly is really an honor. You know what Metabolic Mind and the related organizations have done to advance our understanding and build initiatives around understanding the interaction between metabolism and critical components to our overall health, such as mental health, is undeniable how impactful it has been. And I'm extremely grateful for that as a patient living with a metabolic disease that has direct impact on how my physical and mental health every single day. And trust me, I know it. I could feel it. Patients with type 1 get it. And so I just want to say thank you to you guys and what you guys have done. But I also want to say that I want to advocate for people in this community. We need more evidence. We need guidelines. We need more awareness on this topic that provides evidence-based discussions around the impact that these nutritional strategies can have in the context of type 1 diabetes. And I'm very motivated and hope people follow, because there's a lot of information that's coming very shortly in this context. And there's a lot more that needs to be done. So thank you to you guys for listening. Thank you, Bret, and thank Metabolic Mind for what you guys are doing.
Well, thank you for saying that, but also thank you for what you're doing, because you're not just talking the talk, you're clearly walking the walk. You uproot your whole family, move across the country to take this job to do diabetes research. So you're not just a patient and an advocate, you're a researcher too, doing something about it, really trying to make the changes that you're looking for. So thank you for all your work. And I really enjoyed this conversation, and I very much look forward to hearing more from you in the future about other projects you're working on. So thanks again for joining us.
Hey, thank you, Bret. And if anyone's interested in some of the work we're doing revolving diabetes, check out sansum.org and see what we're doing in the context of lifestyle interventions in the context of type 1 diabetes.